Hello guys, so welcome to today's class. This is the last class for Farre for orthopedics. So I've remembered that I have left a few important topics such as metabolic disorders and peripheral palsy, which is way important compared to all others. So I thought I'll complete this two important topics in this class so that by this class we will complete entire Farre series, which is actually all those important questions we piled up. So this by this class most of the important questions for your prof exams are ready, right? Are you ready for the last class for Farre? So let us start the class without further delay. Before that, uh, video and audio, is it all fine? If somebody could quick say a yes, then we can proceed with our class. Yes. Can you all hear? Okay then. So let us start the class. So we are dealing with both metabolic disorders and peripheral nerve palsy. In the metabolic disorders, there are two important questions. What we are going to deal today are rickets and osteoporosis. And from the peripheral nerve palsy, we are going to deal with the radial nerve palsy and the ulnar nerve palsy. So these four are repeatedly asked questions. So we have picked up these four questions for today's topic. And I'm going to add two important things, that is decurvins and Osgood-Schlatters disease. So this was just asked. So sometimes they will put these questions, no, answer these two questions A and B. So one would be decurvins, B would be Osgood-Schlatters disease. So at the end of the class, we're going to discuss with these two topics and then we're going to close the class. Okay, so that's the plan for today. Let's see how we're going to execute. Okay, so first starting off with the very important questions from ortho, always and integrated questions from the pediatrics, that is your rickets, right? Right, usually in the NEET PG also they will combine it with pediatrics. So let us learn in detail what are these orthopedic aspects. Okay, so first starting off with the rickets, how would they usually frame the question? They would ask you what are rickets, discuss its causes, pathophysiology, clinical features, management and complications. So it is a 10 marks good big question, right? So what is a ricket? So what is rickets? So this is a specific term which is given to a condition usually seen in children, right? Usually it is seen in children. So it is a pediatric disorder. And what you would think is the definition for rickets? Yes, anybody? One word which you can define what is rickets. So that one word would be, it is defective mineralization of the bone, right? So now if I tell this term of defective mineralization of the bone, then you have to understand what is actually this mineral of the bone. Then only you can know what is this defect in that mineral. So if you go back to your basics and understand that bone is made up of two things, right? So one is the organic and inorganic component. You all know that, right? So in that organic component is mainly which is called as osteoid. and this is mainly made up of collagen and the inorganic components, such as it is mineralized with calcium and phosphorus and magnesium. So all these are the minerals which are present in the bone. So once this osteoid is laced by the osteoblast, right, and then now this osteoid is mineralized by these minerals calcium, phosphorus and magnesium in a little bit range. And what is most important is for this vitamin D. So nowadays vitamin D is considered as a hormone, not a vitamin anymore, because it is very much important for various well-being, I mean like various systems and most of the well-being of the human. So in that, the most important thing is the bone mineralization. So this vitamin D is synthesized in the body and this is absorbed by the sun, right? So we will get exposed to the sun, and then so this is called as sunshine vitamin. That is what I wanted to tell. So from the sun UV, then we are going to absorb, we are going to synthesize this vitamin D in the body. I am pretty sure that you would all know what is, the cycle of the synthesis of the vitamin D. So from the skin it gets absorbed, and first it gets hydroxylation for one hydroxylase, that is in the liver, first hydroxylation in the liver, and then the second one in the kidney, right? Liver and the kidney, and there are various enzymes which are attached to it, right? So this is 125 dihydroxycholecalciferol, that is also called as your vitamin D. Right, so this is how vitamin D is synthesized, and this vitamin D, it acts as a carrier. It acts as a carrier for absorption of calcium and phosphorus, which is done at the three places. So what are those three places? One is your bone, second one is your intestine, and third one is the kidney. So these are the three areas where the vitamin D plays an important role in absorption of these minerals, calcium and phosphorus. Hence, it causes the mineralization of the bone. So this is the fast story of vitamin D. So whenever you're writing about rickets, you have to remember that there is some story behind it. The story is this. So that is the vitamin D. So here, who is the culprit? So the culprit, so you all know, you even know that calcium metabolism is usually also taken care by parathyroid hormone. So usually we don't enter into a state of hypocalcemia. It is very rare because our PTH is there for us. PTH is there as a big brother for calcium. So whenever the calcium is low in the body, PTH will play its role and upbring. So it will raise the levels of the calcium. Similarly, whenever it is high in the body, again, there is one more hormone, calcitonin will come in play and it will decrease the hormone, right? So now it will decrease the calcium. That means they will stabilize the calcium levels. So now what is actually rickets? Rickets is defective mineralization of the bone due to low levels of vitamin D, right? So there is a deficiency of this vitamin D, hence there is a deficiency of absorption of calcium and phosphorus, hence the bones are weak. Understood? So this is the story of vitamin D. So now what is the ricket? So definition, what will you write? It is nothing but your defective mineralization of bone because of low levels of vitamin D, right? So whenever there are low levels of vitamin D, then there will be decreased absorption of the calcium, hence these minerals are not put on the osteoid. Hence now what happens to the bone when there is no minerals? Now the bones becomes softened, right? So they soften and they will tend to bend. So this bending leads to deformities. This bending leads to deformities. So whenever there is a weakness of the mineral, the bones become softened. On the other hand, remember in osteogenesis imperfecta, what is osteogenesis imperfecta? Yes, yes, you need to answer now. What is osteogenesis imperfecta? So whenever there is defect in the collagen, right? So there is a defect in the collagen, hence it will result in what? Defective collagen, and now the bones become brittle and they tend to break, right? So they easily break. So hence the patient presents with multiple fractures. Do you understand this? So here the mineral is weak, hence the bones have become softened and they tend to bend, which results in multiple deformities. Yes. And in the defective collagen, in case of osteogenesis imperfecta, the bones become, there is defective collagen, that is osteoid is defective. Osteoid is defective. So minerals are good. The calcium, the phosphorus and all are present, but the osteoid itself is weak. They will make the bones brittle and hence they break, resulting in fracture. So this is the major difference which you have to remember. What is a brittle bone? What is a softened bone? Okay. Yes. And star anonymous star fragile bones. Yes, yes. Defective collagen is fragile bones, but the fragility is because of there is a lack of collagen 1, right? So that is a genetic disorder. So getting back to our mineralization defective, so here you're going to write first the definition. So what is a ricket? You're going to write that is defective mineralization of the bone, because why? There are low levels of vitamin D and hence the bones become softened and they bend and they're seen with deformities, and this is, we all know, usually seen in children, right? Yeah, they are usually seen in children. And whenever you're going to write this, then you're going to understand the causes. So why actually this vitamin D deficiency is occurring? So most important cause is malnutrition. So nutrition deficiency is supposed to be the most important cause. So the first one is nutrition deficiency. Then you might, now you will ask me what are the causes. So this table is very, very important. Now in this table, we are going to not by heart anything. What we are going to remember is just we are going to remember the vitamin deficiency. And as we know the story of the vitamin D, we know the story, right? First, there should be a proper synthesis of the vitamin D. That is, you have to properly get exposed to the sunlight. So we all know that vitamin D is synthesized by us by the exposure to the sunlight. So the first very, very important cause would be lack of exposure to the sunlight. And sometimes, not only the sunlight, you have to have proper intake of calcium and phosphorus also, because even though the carrier is present, the minerals should be present in your diet so that they get absorbed. So diminished intake, that is malnutrition. So malnutrition, lack of exposure of the sunlight, and next comes the malabsorption syndromes. So for example, if there are any gastric and biliary diseases, the malabsorption is, even though the carrier is present, they are unable to absorb the calcium. So these are called the malabsorption syndromes. So these three are the first vitamin deficiency causes. And next, then where any disturbance in the abnormalities, for example, we already know that liver and kidney are the two important things. So liver and kidney are the two important things. So if there is any problem in the hepatic issue, if there is any renal issue, right, or if there is any interference with the vitamin D, for example, your drugs, for example, your anticonvulsant therapy, that is phenytoin, if it interferes with the vitamin D metabolism, right? And again, this is renal osteodystrophy is the end stage, right? Kidney disease, end stage. So these are the vitamin D metabolism disturbances. And they, if you remember, so this this rickets can be as two types. So type 1 rickets and type 2 rickets, right? So type 1 rickets is, So type 1 ricket is directly because of vitamin D, and type 2, what you have to remember is this could be because of vitamin D resistant rickets. That means even though if you give vitamin D to the patient, the patient will not respond. So this is, then we will understand that this is vitamin D resistant. So what are the reasons for it? The most important reason could be phosphate absorption. So whenever there is problem in the phosphate absorption, here there is no problem with the calcium. Here the problem would be because of phosphate absorption. So there are certain diseases which you have to understand. So they could be hypophosphatemic rickets, that is X-linked dominant, which is the most important one which you have to remember, that is hypophosphatemic rickets, which is X-linked dominant, and the gene responsible for this is the FEX gene. And here what happens is FGF23 is the substance which is present in a higher levels, which will inhibit the phosphate absorption. Then it is renal tubular acidosis, again a kidney related disease where the phosphate metabolism is impaired. And there is one more called the oncogenic rickets, which may also result in defective absorption and then will result in vitamin D resistant rickets. Okay. So these are the type 1 and type 2. Just don't get confused. Type 1 is vitamin D dependent. So whenever you give vitamin D, this is corrected. But there is a type 2 which is called as vitamin D resistance. So vitamin D resistant rickets ka matlab, that means what is the meaning of it? That means even though you supply them with good amount of vitamin D, they don't recover. Hence you have to understand there are other causes for this rickets, and that the main thing is phosphate. So there would be disturbance in the phosphate metabolism. The first one is hypophosphatemic rickets, which is an X-linked dominant. And then we have renal tubular acidosis and oncogenic rickets. And then your, diminished, as we know, it is again related to nutrition. Okay. So these are type 2 hypophosphatasia. That is also one more thing. Hypophosphatasia is wherever there is alkaline phosphatase ALP enzyme deficiency. Hypophosphatase, right? And this is your CKD again, right? So these are the various types of rickets, right? So these are various issues which you have to look in a patient who is presenting you with the rickets. Fine. So this is one table which you're going to remember whenever you're going to answer this. So whenever you're going to write the answer of the rickets, so you're going to put this table, okay? And then, so now we have understood so much about the causes, so much about what had happened, why actually this rickets is happening. Now we will understand what will happen if there is vitamin D low levels, then which leads to decrease in calcium and decrease in the phosphorus. Then what is the pathology? So where actually this pathology is occurring? So now for that you have to understand that growing bone. So growing bone, if you see, there is a growth plate, right? So there is a growth plate which increases the length of the bone. So what happens here? So here, if you see, these are the growth planes, and in this growth plate, if you take and zoom this growth plate, you will see various areas. So this is your epiphysis. This is your epiphysis, and this will be your metaphysis. So I am going from the epiphysis to the metaphysis, and this area between is called as your growth plate. That is what we are talking about, right? So starting from the epiphysis, the first one is the reserve zone where your stem cells are present. So this is the area where your stem cells are present, and any damage to this particular area is unforgiving, right? So there is no forgiveness. There will be disturbance in the growth. So whenever the stem cells, the reserve is damaged, so there will be a growth disturbance which can occur. Okay, but we are not much interested here because our calcium and phosphorus has nothing to do with their reserve zone. So we are nothing to do with the reserve zone. Next comes the proliferative zone. So proliferative zone, here where the chondrocytes increase, right? So this is the area where the cartilage cells will proliferate. What is the proliferation? So what is proliferation? Proliferation is nothing. Proliferation is you increase in the number, right? So there will be increase in the number, right? And then there is maturation and hypertrophy zone. So zone of hypertrophy, you would have been aware of this. No, this is the weakest area where there will be fracture occurring. If at all it is the, for example, your Salter Harris type 1 fractures. So this is the zone of, this is the weakest zone where usually the fracture of the physis occurs at this area. So what will happen here? So here what happens is the chondrocytes, they start accumulating the all your minerals, then they get matured here and they get increased in the size. And then the calcification actually occurs. So this is the calcified matrix. As we are moving towards the metaphysis, there is a role of calcium and phosphorus. So the role starts right from here, the zone of hypertrophy, and then the calcified matrix. So here, this is the area which is getting affected by your rickets. So this is the area which is affected by rickets. So now what happens? So the chondrocytes keep on proliferating, and then they get accumulated with lipids, collagen, and then they get calcified, and then they go into the metaphysis. So here, because there is no calcium and no phosphorus, so the chondrocytes keep on increasing in number, which will result in widening of metaphysis, right? Widening of metaphysis, right? So then this widening can be seen on the x-rays and cupping, and then there will be some disturbance which is called as fraying and splaying. So that is why we go and take the x-rays of the wrist, so that you will see there are some changes in the growth plate, and that changes are usually in the metaphyseal area. So in the metaphyseal area, so there will be widening of the metaphysis, which can be seen as cupping, fraying, and splaying. These are the three important terms which you have to remember in case of the rickets, which is happening at this area of growth plate. Is this clear? Clear, everybody, the pathophysiology of rickets? So if you're going to answer in the exam, the pathophysiology, you have to start right from the vitamin D, and then you can draw about this, then you can write about this growth plate, right? So you're writing about the vitamin D because we are telling that this is because of low levels of vitamin D, right? So then vitamin D is synthesized, and then where it is synthesized, I mean, you can just draw a picture of it. So it's synthesized in the liver and the kidney, and this acts at the three areas: the kidneys, the bone, and the intestine. That's it. That is the starting stage. Then next step is, because of this decreased levels of vitamin D, so and so problem is occurring. So what is that problem? There is no deposition of calcium and phosphorus, and that is mainly in the area of growth plate. So that area is mainly in the calcified matrix area of the that is zone of ossification. We say it as zone of ossification, right? So what happens, because there is no ossification which is occurring, the chondrocytes get accumulated here, and this is seen as widened metaphysis, right? And now, what are the various changes that has occurred? So this depends upon the age of the patient. So now once the pathophysiology is done, then we have to understand what are the clinical features. What are the clinical features which we see in case of rickets, right? So that depends upon the age of the patient. That means if the patient is having vitamin D since his birth in the infant, okay, so then there will be few important things. So here what you can see is your delayed closure of fontanelles, the craniotabes, sutures get widened, and then there would be frontal bossing. So what is craniotabes? Craniotabes delayed closure of fontanelle, right? So what is craniotabes? Yes, anybody? What is craniotabes? So this is also called as ping pong ball appearance, right? So because I told you, no, the bones get softened. So directly it starts with the skull. So the skull bones are softened. Hence you can press the skull bones and there is a dip in it like your ping pong ball, right? So that is called the craniotabes because of the softening of the skull bones. Then there will be delayed closure of the fontanelles. Then there will be dental hypoplasia. So again, because of the decreased calcium levels, there will be growth disturbance in case even in the dentition. Then what you have to remember, then there were three important things which you have to remember in the chest. So in the chest, the first thing is rachetic rosary. What is rachetic rosary? So here what happens is this is the costochondral junction and this is seen as a beaded appearance. So because of the swelling or the prominent appearance of the costochondral junction, it is seen as a beaded appearance. So it looks like this. So what is a rosary? Rosary is Japamala. We call it the Japamala, right? So it is like this. So this is the rachetic rosary. And then they will have a indentation in the diaphragm. So diaphragm indentation, this is called as Harrison sulcus. Right? So this is the Harrison sulcus, right? Inward pull of the diaphragm, right? And then what you have to remember is pigeon breast deformity. So this is called pectus carinatum. So you will have a pigeon breast appearance. And then I have told you that there will be widening of the metaphysis, which they appreciate it as some increased swelling in the wrist and the ankle joint. And again in the legs, what you see because of the softening again. So this is the most important deformity, softening, which results in bowing of the legs, which you can see as genu varum usually, or sometimes genu valgum, or sometimes as wind swept deformity. So what is a wind swept deformity? Yes. Yes, what is a wind swept deformity? So if you see, there is both varus and valgus. So one knee you will see varus, the other knee you see valgus, which is called as a wind swept deformity like this. So one is varus, the other one is valgus. Yes, very good, Rakesh. So that is called the windswept deformity. Characteristic, it is seen in your rickets, right? Rickets and even in your rheumatoid arthritis. So these are the two important conditions where you can see the windswept deformity. So now whenever you're going to answer rickets in the exam, the first thing is you're going to understand the pathophysiology. So definition, pathophysiology, and there are two important tables. So first table you're going to write about the causes, type 1 rickets, type 2 rickets, and then the clinical features depending upon the age we are going to write. So this we see in the growing age, right? Once the patient starts walking, then you can see the deformity in the limbs, right? So this is one more table which you have to remember. So in case of infants, you will see this craniotabes and bossing of the skull mainly, right? That is called the frontal bossing. And as the age advances, you can see there would be brachiatic rosary, pigeon chest deformity, Harrison sulcus. And because calcium is also very, very important in muscle contractions, if you remember, the sarcoplasm reticulum will have the calcium, right? The calcium channels. So whenever the calcium are weak, this will result in weak abdominal muscles also, which we see as pot belly. So in the abdomen, you will remember the pot belly. So starting from the skull, then the dentition, then the chest, then pot belly, abdomen, then coming to your limbs. So limbs, you see, what you see whenever the patient starts weight bearing, broadening of that, broadening of the metaphyseal, that is in the wrists and the knee, usually we'll see. And then you see the deformities, that is knock knees or bow legs. Bow legs is genu. What is bow legs? And knock knees. Knock knees is valgum, right? Bow legs is genu varus. And then Harrison's groove. And then this is all we have learned, right? So usually lumbar lordosis is not much appreciated. It is seen at the later age, but bone pain is usually seen. Practice again at a later stage. But remember these two. First is broadening, then is deformities. That is varus and valgum. Valgum is something like this, like knock knees. Bow legs is varus. Right? So that is about your this one more table, that is about the clinical features which you have to remember, right? So you will draw you can just draw a diagram like this, and then even you can name them. So you can add a pot belly here, right? This will give a more good impression to the examiner, right? And then once we are done with the clinical features, then where we will go, we have to go for the investigations. So investigations, you know what to investigate: levels of calcium, phosphorus, and vitamin D, alkaline phosphatase. So these are all the things which we take into consideration. And then the most important investigation is X-ray. So radiograph of the wrist, knee, and ankle. But usually what we take is X-ray of the wrist. So you will advise X-ray wrist, that is bilateral X-ray wrist, right? And now what you see, so these are very, very important. You're going to see the most important. So you're going to observe the most important things. So what we are going to see? So what is the first feature? What is this? So this is the end of the long bone. So growth plate end, right? So in this, what you're going to see, first thing what we see is widening. So you will see there is an increase, right? So usually the physis, what we see, physis is just a straight line, right? But here you see there is a widening of the physis. So that is the first thing you notice. So widening of the growth plate, right? And this widening can be appreciated in the form of cupping of the physis, right? And then you can see this is the fraying, right? So this is the fraying. So fraying is the edges, right? And then you can see this extensions here. So this is your splaying. So all this is observed mainly in the metaphyseal region, right? And then you can see ground glass appearance. Right? Yes, very good. So this is the widening of the physis. Then no changes near the physis, epiphysis end. If you see, there is no changes in the this area, The whole of the pathology is occurring in the metaphyseal area, right? So this metaphyseal, this is the cupping. So you see, because of the widening, it goes into cup-like shape. This is called cupping, and these extensions are called splaying, and this is called the fraying. So if you see, these edges are like this, no? The ends of So this is the fraying, right? This area, this is area for fraying, right? So these are the important things which you are going to observe in case of X-ray, especially in the wrist joint. So you're going to take the X-ray, bilateral X-ray, and then you're going to note these changes, right? Yes. And then what is this? See, now here you can see the fraying. So this is the fraying, right? See, this is again a cup-like shaped splaying, and this is your fraying. And most important thing, what you can see, there is a bending here, right? So there is a bending or bowing of the legs. Understood? So this is the bending or bowing of the legs in X-ray of your leg, right? And then what you do? So now you confirm that there is rickets. So now how do you manage? So with the X-ray, with the clinical features, with the history, we came to know that the patient is suffering from rickets. Now, what is the management? As we know that the pathology or the culprit is vitamin D. So we will supply them with vitamin D. So here you will have two things. So you will give them a dose of initial dose. You give 6 lakhs international units, right? And then the maintenance 400 international units. So this is for vitamin D, and then you will always combine with calcium supplements, right? So this is the initial dose. So you'll give 6 lakhs international units IM, and then you will give 400 international units along with your calcium supplements. And usually the tablet form is vitamin D plus calcium. And if you want to go for injection, it is depot, right? Ergocalciferol. Depot injections we give, right? So this is how we manage the case. And once we treat them with vitamin D, then you will see what is called as healed rickets. So now again, you will repeat the X-rays. And here you can see a very good closure of the physis. So you can't see all this cupping, fraying and splaying is absent. Before you will see the rickets are in healing stage. So there was a lucency, right? Complete lucency. Now you will see some amount of calcification. And then after 6 to 8 weeks of the treatment, you will observe this. So this is vitamin D dependent rickets. So the patient is responding to a treatment, then you call this as vitamin D dependent rickets. And this is type 1. If the patient is not responding for even a dosage, then you will have to analyze for vitamin D resistant rickets. That is type 2. Is that clear? And what do you think would be the complications? So when you don't treat, the patient may land up with more deformities, right? And he can have growth disturbances later. And sometimes as the bone becomes very softened, it will result in fractures, right? So these are the complications which we expect in case of your rickets, right? So this is the answer you're going to write. So we have done with the causes, pathophysiology, the clinical features, the management and the complications. Is that clear? So you will start writing from the vitamin D, and then you're going to understand and write the causes. There's no by hearting type 1, type 2. If you know the pathology well, you will going to write this as a table, right? And then you're going to write about the pathophysiology, that you're always going to start with vitamin D metabolism, then you're going to end up with the growth plate. Then the clinical features, very neatly you can put it as a table, or if you're good at drawing this diagram, you can just draw this diagram and write. they're almost like 8 or 10, just remember. And once you understand that the softening of the bones is the cause, then you will not forget the craniotabes. That is nothing but your ping pong ball appearance, that is craniotabes. Then delaying wide end of the sutures or delayed closure of the sutures, that is in the skull. And frontal pausing, these four are seen. Then comes to the mandible, that is delayed dentition. Then in the chest there are three: rachatic rosary, Harrison sulcus, pigeon shaped breast. Then the abdomen, the abdominal muscles are weak, hence results in pot belly. Then in the limbs, you will remember as widening physis or swellings. And then there would be deformities like the bow legs or the knock knees. Okay, so these are the clinical features. And then the x-ray findings are very, very important, because the examiner will look up for these x-ray features, because this is how we diagnose the rickets. It is a radiological diagnosis, right? And then you're going to write the management. How we are going to manage it is usually easy. We give vitamin D plus calcium supplements, and then you will result after 6 to 8 weeks. You will see the result. And if at all patient is not being treated, then he might result in complications such as deformities, growth disturbances, and ultimately may also lead to fractures. So that is about your rickets. Is that clear, everybody? Yes or no? Yes. So our next question would be about osteoporosis. So now let us deal with osteoporosis, right? So once we are done with the rickets, which is in children, now we are going to the other extreme age, that is the elderly or the senior citizen above 50 years of age, right? So this is the age where we usually see a condition which is called as osteoporosis, right? Rakesh, are you there? So what is osteoporosis? Again, we have to understand, define, that is definition of osteoporosis, which is very, very important. Then you're going to understand what is the pathophysiology, what has led to this condition, the causes, right? And then you will see how will you diagnose, that is the clinical features of osteoporosis. Then management, which includes the investigation and the treatment part, which is very, very important, right? Right, these are the things which we are going to understand in case of osteoporosis. Now first, coming to the definition, what do you think is osteoporosis? So this diagram, whenever you put in mind, it will if female has PCOD and have hormonal imbalance, then is it possible that she will suffer from osteoporosis even at a young age? It is not always true that in case of PCOD she will suffer from osteoporosis, but she might develop at an early stage. It is not that very young age she will suffer from it, but she might develop it at an early stage. For example, if a normal woman uh, usually develops after 50-55 years, these persons of PCOD, if unrectified, if they're not treated properly, they might start developing it from 40. Okay, not a very youngster, now like 25-26, they don't land up in osteoporosis. Oh, there is a problem in the voice. Is it clear now? So what I was actually telling is, yeah, you understood. Okay, thank you. Mohammed, can you hear me? Nitish has heard. No, I think there's a problem with your thing at your end. What about others? Can you hear me? Okay, Nitish has confirmed. Okay, now let us see what is osteoporosis, right? So whenever I'm talking about osteoporosis, the one thing, the one image I want to flash in your mind is this particular image. If this is seen, if this appears in no voice. Hey, might be you have put your laptop in no mute. So this is the picture. So see, if you see the porosity has increased here, right? So if you see, this is the normal bone this is. And if you see here, this is the porous bone. So this is called as osteoporosis, okay? Increase in the porosity. Right? And now if you see, but why actually this is appearing? Because the most important problem here, what you have to remember is the bone mineral density. Understood? So these three words are very, very important whenever you're talking with whenever you're talking about the osteoporosis. That is the word bone mineral density. So whenever there is decrease in this bone mineral density, then you say that is osteoporosis. Similarly for rickets, what did I tell you? The magical words defective mineralization. So the minerals which are there are not properly placed, right? So they are not properly present in the bone, hence it is getting softened. Here what is happening, the mineral is present, the osteoid is present, but the quantity of it is decreased, right? So here this is the quantitative defect. Quantitative defect, that means there is a decrease in both osteoid as well as the mineral. So both are decreased here, right? But the ratio is maintained. So in case of osteomalacia, so you have to not get confused between osteomalacia and osteoporosis. So what is osteomalacia now, guys? Yes. What is osteomalacia? I think Mohammed has left. So what is osteomalacia, Nitish? Rakesh? Yes, come on. What is osteomalacia? Very, very easy, very, very important. So whenever there is vitamin D deficiency in adults, so this is a condition where we see in adults. So yeah, very good. Rickets like features in older age. Older age is adult. So whenever there is vitamin D deficiency in the adults, it is called as osteomalacia, right? So here in the here this is the osteoid is normal, right? Osteoid is normal, but mineral is low. So mineral is low. Here both osteoid and the mineral both are low. So when you take osteoporosis, osteoid is low, mineral is also low. So that is defined as your bone mineral density. That is low levels of bone mineral density. So here it is qualitative defect. The bone quality is disturbed. Here quantity, right? So both the osteoid and mineral both are disturbed. Is that clear? So this is about the osteoporosis and why actually this occurs. So why there is a decrease in the bone mineral density. So for that you have to understand what are the causes of it. So what is the main cause of it? So first main important cause is senility. So as we grow older, there will be decline in the bone mass. Hence this is decrease in the bone mineral density. The bone mass is decreased and bone mineral density is decreased. So senility is one of the most important cause, right? The senility. Ginger GP, what is that? You can please type it in English. So first is the senility. Next, most important cause is your postmenopausal. So this is related to the hormonal changes in the females, especially the hormone estrogen is very important, is increasing the bone mass. So whenever there is a decrease in the bone mass because of the decreased levels of the estrogen, the patient will end up in osteoporosis. So the two important causes where you have to remember is first the senility, the next is the postmenopausal, and and the next are the drug induced. Whenever a patient is treated with high or the long-term treatment with steroids, then they might land up in osteoporosis. So drug induced is steroid, especially which drug you have to remember is steroids, right? And these are the three important causes, right? So the first is the age related, that is senility. The second one is the postmenopausal, and the third one is drug induced. Then comes your inadequate intake. So that is malnutrition, again deficiency of your calcium and your diet abnormalities, malabsorption, malnutrition, right? So these are protein deficiencies. So whenever there is malnutrition, malabsorption, diet related problems, right? And the final one, what you have to remember is in case of bedridden, this is again atrophy. So you can remember the Wolff's law where the weight stress is very important. So if you weight bear, there will be increase in the bone mass. But whenever there is a bedridden patients, not bearing weight, then the bone will think, then the long bones will think that they are of no use and the calcium completely gets absorbed into the blood. So then that is post immobilization, or in case of a bedridden patient also you can see osteoporosis. And finally there are certain disorders such as Cushing's disease and hyperthyroidism where you can see a osteoporosis again. But what you will remember, the first one is age, so increasing age. Second is postmenopausal, so most very important reason in case of females what we see is postmenopausal, that is because of the hormone estrogen. And the third one, what I told you, drug induced. So usually whenever you treat with high doses of steroids, especially patients suffering from asthma, you will see they can land up with osteoporosis. And fourth one is diet. So whenever there is diet intake such as malnutrition, malabsorption, all this come under the fourth category. Fifth one is your immobilization, that is if they're prolonged bedridden, right? Prolonged bedridden patients, they may also land up in osteoporosis. And finally what you have to remember is certain endocrine disorders such as Cushing's disease, Cushing's syndrome, and hyperparathyroidism, right? So these are also, so these are also condition where you have to remember this patient might land up in osteoporosis, right? So these are the causes. So causes are very important. And there are certain risk factors also. Risk factors such as if the age, again age is more than 65 and age more than 75. This is in case of females. This is in case of males. And again, if the patient is on corticosteroid therapy, as we said, this could be one of the cause. And if they are on alcohol, very important, smoking, very important, and any evidence of fragility fractures. What are fragility fractures? So if at all they had any fractures with minimal trauma, that is distal radius fracture, vertebral fracture. These are called the fragility fracture. So whenever they present to you with this fragility fracture, so these are all the risk factors. So this risk factors, these patients has to be sent for screening. So these are all the risk factors also. So these risk factors you have to put in mind. So whenever you see a patient with these risk factors, age and corticosteroid therapy and alcohol, smoking, fragility fractures. So these are all, and again any endocrinal disorders also. So all this are to be put in your mind. So all these patients, you have to counsel them that you are at a risk of developing osteoporosis. Hence, you have to screen them. You have to start with appropriate treatment for those patients, right? So these are the risk factors which you have to remember. Next, let us understand what are the clinical features. Right? What are the clinical features of these patients? So how they usually present? So first, they usually present with pain, especially in the vertebrae, and they might land up with kyphosis. So because there is vertebrae length which is decreased, so they would be bending. This is called as forward bending. Term given is the kyphosis, right? So they appear to be shortened. So their height also gets shortened, right? The height also gets shortened. So why, before that, let us understand pathophysiology. I forgot that. So pathophysiology, there is nothing much, because here what actually happens is there will be increase in bone resorption and they will decrease in bone formation. So this is the main thing which you have to put in your head. That's it. Osteoporosis is nothing but there is an imbalance. So there is an imbalance. So the balance is imbalance. So here what happens is, again going back to the dynamics of the bone. So how the bone is synthesized. So you all know that there is osteoblast, and this osteoblast will be laid the osteoid, and then this will be mineralized, right? So whenever this process is happening and whenever there is decrease in the calcium in the blood, what happens is now all the hormones will act in favor of increasing the calcium in the blood. So they will absorb the calcium. So bone is nothing but the storehouse of calcium, right? So oh, Zeus Khan, I'm sorry. Today we have scheduled it at 6 o'clock, Farre. You have to follow one of the Telegram group of PW, or on Insta also we keep posting the classes, okay? From next time you can follow Insta, and you can get the updates of all the classes happening on PW, okay? Okay, now you're not late. We are just completed rickets and now we are in osteoporosis. So I'm teaching the pathophysiology of osteoporosis. So here what is happening in pathophysiology of osteoporosis is, so we know the dynamics of the bone. So bone is considered as the storehouse for calcium. So whenever there is low levels of calcium in the blood, what happens is they take the calcium from the bone. They suck the calcium from the bone. So here in osteoporosis, what happens is, because of all these factors, this could be, as they are aging, or they could be decreased in intake, decreased in the bone mass, or corticosteroids acting, or decrease in the estrogen. What happens is the patient will have more of bone resorption. So more of calcium is taken out from the bone, and the formation of bone is decreased. So there is an imbalance of formation and resorption. It's like, just think that you're in the kitchen and you're cooking. So people are eating there and you're cooking. If eating rate is increased, the cooking rate is decreased, what will happen? We become deficient of the food, right? So similarly, what happens in the bone also, we keep on eating calcium from the bone. So what happens to the bone? Now the bone becomes weak. this weakening is seen in the mass. So the bone mass is decreased, which is termed as BMD. That is, this will result in low bone mineral density. So that is the pathophysiology of the osteoporosis. Just remember, it is because of the increased resorption and decreased bone formation, right? And now the clinical features. As the bone is weakened, what will happen is, first changes usually we see in the vertebrae. So the vertebrae, the height of the vertebrae decreases, and hence as we age, our especially the grandmas, right, usually the females, they result in hunch, right? So this back hunching is seen in most of the females. They bend like this and walk. So this is one of the reason of they develop these kyphosis. So this is called vertebral kyphosis, usually seen in osteoporosis. So one of the main important thing is your vertebrae features in the vertebrae. And the second one is fragility fractures. They usually present with fragility fractures. So what are these areas where you have to commonly look for those fragility fractures? So the first one is your most important, that is your distal radius. So distal radius, you all know, postmenopausal woman, we see distal radius fracture, which is called as the Cooley's fracture, if you remember, right? And the second one is your vertebral fractures. As I've told you, the vertebral fractures. And the third one is the hip fractures. So in the hip fracture, specifically the neck of the femur fracture, that is your intracapsular fracture, IC fracture, right? So these are, in vertebra, it is usually the wedge fractures. The wedge fractures which we see are usually related to the osteoporosis. So now the patient might come with multiple, bone pains and, back pain usually they come with, and then they come with these fractures, right? So you have to, once you see a patient with Colles fractures, then this is a stage where you have to diagnose with osteoporosis also, right? Then you will see for the risk factors of this particular patient, and then you will start the treatment of osteoporosis also in this particular patient. Similarly, if you see a patient with hip fractures, then again you will analyze this patient for risk fractures, and then you will put on the osteoporosis treatment. So these are the some of the important clinical features which we see in cases, that is fragility fractures and this kyphosis, right? So this is most important clinical features which we usually see. And now what are the investigations what we are going to do? So the most important thing, as I've told you, is the screening or the investigation, that is your DEXA scan. So what is DEXA scan? So this fractures we usually see in the radiology, right? But there is one more important screening test, or you can diagnose the osteoporosis with the help of DEXA scan. So what do you mean by DEXA scan? It is also a type of X-ray, dual energy X-ray absorptiometry. It is also type of the X-ray where you see mostly in the calcaneum or the vertebrae. So there you will analyze the bone mineral density. Okay, DEXA is dual energy X-ray absorptiometry. It is low radiation. We take in these areas of calcaneum or vertebrae, right? And then we'll calculate the bone mineral density of that particular area. And now going back to our SPM, we can analyze T-scores and Z scores, right? So what are actually the Z scores? Z scores are mainly when they're matched with the same age and same sex, right? T scores are usually when they match with the young individuals, right? So here bone mineral, yes, BMD is bone mineral density. Very good. So now T scores and Z scores. This we take the BMD, that is bone mineral density, will calculate, and then we will observe the T score of that particular individual. If it is less than 2.5, that is, this is what is that standard deviation we take along with the standard deviation, right? So standard deviation is this curve, this is the normal. So how much it is deviated from the normal, that is the standard deviation, right? So if it is minus 2.5 standard deviation, then you will consider it as osteoporosis. So this is osteoporosis, right? This is osteoporosis. And whenever you see the same patient with less than 2.5 plus some fragility fracture, then you will take this case as a severe osteoporosis case, right? So this is, if it is from 1 to 2.5, it is osteopenia. That means almost it is pre-symptom of your osteoporosis. That means there is a decreased, but it is not as osteoporosis, right? And normal is -1 deviation. -1 deviation is normal. If it is -1 to anywhere between 2.5, it is osteopenia. Then if it is more than deviation of -2.5, then only it is considered as osteoporosis. Okay? Clear? Any doubt? So this is most important DEXA scan what we are going to do, right? And severe osteoporosis is, as I have already explained, what is fragility fracture, and whenever you see this deviation of -2.5, right? So now tell me, what could be the biochemical investigations of this osteoporosis? This is an important thing. Values. What do you think the values of calcium, phosphorus, vitamin D, alkaline phosphatase, what will happen to all these values? Will they be increased or decreased? Yes. Faster? Rakesh, Nitish, Zuviskan. What will happen to all these values? So, to your surprise, these all will be normal. Right? So the calcium, phosphorus, vitamin D, alkaline phosphatase are normal. So vitamin D, we know it is normal because this is not osteomalacia, so it has to be normal. Alkaline phosphatase, it is mainly increased in bone formation, but here it is bone decrease in bone formation. So this is again normal. And calcium and phosphorus are maintained normal. We take them from the bone and we will maintain that levels normal, right? So usually all these levels are normal, but sometimes you can see calcium at a lower range. So if the normal is somewhere about 9 to 12, you will see somewhere in 9. Okay. So that is the, usually the, all your blood reports will be normal, right? In case of your osteoporosis. This is one of the most important question. Usually they will ask in case of your NEET PG. So that is the DEXA scan. And then when we go to the radiograph, so X-ray of vertebrae, what you see in the X-ray of the vertebrae, the first is reduction in the height of the vertebrae. So that is usually seen as wedge shaped, right? Reduction in the, why normal? I have told, right? The calcium and the phosphorus, the bone takes this calcium and phosphorus from the body takes the calcium and phosphorus from the bone and it will maintain normal, right? Understood? Zuiskan? So here, if you take all these values, for example, calcium and phosphorus, I told you the body will take this calcium and phosphorus from the bone to maintain the normal blood levels. That is normal. And vitamin D is normal. The calcium is normally observed, but here the bone mass itself is decreased. That is, bone itself is weak, right? Then alkaline phosphatase. So usually alkaline phosphatase is an indicator of bone formation. Here there is a decreased bone formation, right? But that doesn't show on the enzyme level. That doesn't usually it will be at the lower level again, like the calcium. But whenever you see all these values, you will see them as normal on the blood investigation. And until and unless you take the X-ray of the vertebrae or the wrist joint, you will understand that the bone mineral density is weak. And one such X-ray is this. So if you see, this height of the vertebrae is usually decreased. So this is the height of the vertebrae, what I was talking about, right? So this is decreased. And the next thing, what you see? Fish mouth or codfish appearance, right? This is again because of that decrease in the height, you will see like this. So the vertebrae is something like this, right? So this is the appearance of the vertebrae. Usually it has to be like this, okay? And then you see fracture and kyphosis. So all these are the radiograph findings which we see in case of your osteoporosis patient, right? And now this, you see, what is this appearance? This is your classical or the fish mouth appearance, right? So this is what I was talking about, the height. You see, this is called the wedging, right? So this is the wedging. Clear? Yeah. And now you see the most important, the Colles fracture. So even on the trivial trauma, so what is trivial trauma? Just fall from the height, even slip and fall. So they will just and slip and they will fall, and then they will come with this extra articular fracture of the distal radius, which is called as the Colles fracture, most commonly seen in the post-menopausal women because of osteoporosis, right? So this is the one thing for your fragility fracture. So you have to remember that they can come with a distal radius fracture or a vertebral fracture, or just the appearance of the codfish or fish mouth appearance of the vertebrae. And then they can come with what is called as the hip fracture, that is IC fracture. So that also you have to remember. Hip fracture, neck of femur, right? So these are the three important areas where you have to remember that fractures can occur in case of osteoporosis. And one more thing there is, which is called as Singh's index. This is for grading of osteoporosis. So you want to grade the patient, in which grade she is present. So for this, we take the help of the trabecular pattern, which is present on the head and the neck of the femur. So if you just take any X-ray of head and neck of femur, so this is your, the femur X-ray, AP, pelvis. So tomorrow if you go to your wards, then take a AP, pelvis, X-ray. So here when you zoom and see, right, or when you just see it clearly, you can see some patterns like this. These are not just lines, so they have some significance. These are called the trabeculae. The trabeculae, if you see this particular trabeculae is like this, right? And you can see there is one more trabeculae, it is like this, right? So these trabeculae have a separate pattern. So these are the trabeculae. So there are two types of trabeculae. You have to remember, compressive and tensile. So you know there are two regions of a bone. So one is called the compressive and the second one is tension. Tension is elongation, right? So one part of the, whenever you put weight over that particular bone, especially femur, it has two sides. One is compressive side, the second one is tension side. So tension is usually on the lateral aspect, compression is on the medial aspect, right? So compression is usually smaller. So it is compressed, it is tense like this. So here what are two important principal groups, that is principal compressive, principal tensile, like that. Secondary compressive, secondary tensile. So you have to not remember these all, just remember that there are trabecular pattern in compression and tension group, right? So primary, secondary, that's it. And then there is one important, that is greater trochanter trabeculae, that is one separate entity. Like this, there are 6 patterns which you can identify. 6 patterns, right? So these 6 patterns are trabeculae, which you see on the head and neck of the femur. Femoral head, right? Just remember it is femoral head. Now, based upon this absence of the trabecular pattern, you can grade the osteoporosis. That is what has been developed by the Singh. Hence, this is called as Singh's Index of Identification of Osteoporosis. So, coming to the grade 6, if you see grade 6, you can see all the groups, all the trabeculae are present. Right, all the trabeculae are present. Can you identify them? So all the trabeculae, all the 6 trabeculae are present, right? And now coming to the grade 5, you will see this is absent. So one grade is absent. Understood? So usually it is starting from the tension side. So the trochanteric group, then the tension side is getting absent. Then finally the compression side is getting absent. So this is grade 1 and this is grade 6. So whenever you see grade 6 is normal and grade 1 is severe. Right? So it goes this pattern. So remember, first is the tensile group which is disappearing, then it is the primary compressive group that is at the last. So this you can identify on the x-rays as well. You can identify on the x-ray as well. Based upon the trabecular pattern, you can quantify or you can grade the osteoporosis. Just remember the word grading of osteoporosis is by Singh's index. Singh's index. So how that Singh has done that? Based upon the trabecular pattern. So based upon the trabecular pattern. Okay. That is the one thing. So you are going to not forget writing about DEXA scan whenever they're asking you about osteoporosis. You're not going to forget to mention the radiographs of these 3. That is IC, distal radius and vertebrae. And then if you write about Singh's index, and then they will give you all the marks, right? So that is the investigation part. Then finally the most important is your treatment. So treatment, pharmacological treatment, you can always club with the pharmacology, but there is an multi-approach, multi-approach how to treat the osteoporosis. This is very, very common and you have to start treating it in multiple levels. So first you're going to remember is, this is the mnemonic which I found on the net. So usually you should stop smoking first. So all the risk factors. So you have to tell the patient first to quit alcohol and smoking, right? Quitting of alcohol and smoking, that is change in the lifestyle. So change in the lifestyle. So first is your lifestyle modification or lifestyle modification. So what is that? You're going to quit alcohol and smoking. And the second one, you're going to start exercises. So why exercises? Again, going back to Wolff's law. Whenever you put stress on the body, whenever you put stress on the bone, it will increase the bone mass. Whenever there is no stress on the bone, for example, you're sleeping all the time, you're sedentary all the time, so there is no work for the bone, then the bone will think, okay, we are not of much use to this particular individual, and then they give calcium, whatever, somebody is asking for calcium, they give calcium to them and then they become weak, right? So that is why you have to do your exercises regularly. Exercises has to be done regularly. And now the recent studies have told that nothing can prevent the fragility fractures. The most important thing which can prevent is, which can stop this fragility fractures is prevent falls. So prevention is very, very important. You have to always educate the elderly population about falls. So once they fall, again they get restricted to the bed, again again they enter into this vicious cycle of, you know, again bone atrophy, again increasing the osteoporosis. So you have to prevent fall, especially in elderly population. You have to educate them how to use the railings. You have to always use the railings, wet floors, especially in the washrooms. You know, you have to use this anti-squid mats. Proper railing should be placed for them, you know, not to fall. So you have to prevent fall. And very, very important is nutrition. Very, very important is nutrition. That is your diet modification, which are rich in calcium, which are rich in phosphorus, which are rich in magnesium, has to be taken, and the proper exposure of the sun. So these are all the lifestyle modifications which are very, very important, and you're going to mention, right? And then coming to our pharmacological treatment. So here the pharmacological treatment starts with the good supplementation of vitamin D and calcium. So always you are going to start your osteoporosis treatment with the supplying calcium and vitamin D. And then your actual treatment of osteoporosis is your bisphosphonate, right? Bisphosphonates. So here what you have to remember is, going back to pathophysiology, we know that there is increase in bone resorption, right? And decrease in bone formation, right? So now we are going to look at the drugs which will decrease the resorption. So one such drug here is your bisphosphonate. So they will decrease the resorption. So here we have these drugs which can be taken daily, monthly, weekly. Usually bisphosphonates we give weekly, monthly, and yearly. So now alendronate and risindronate we give weekly, right? And monthly you can give ibedronate, and yearly it is zoledric acid, right? So these are the drugs which we usually prescribe. The dronates, these are called the bisphosphonates. So alendronate, risindronate, ibedronate, and zoledric acid, right? So these are usually taken weekly, but always supplemented with calcium and vitamin D. So calcium, vitamin D has to be given, and then you have to treat them with bisphosphonates. So these are the bisphosphonates. And then what are the various treatments modalities? If you see, then we have the denosumab. What is this denosumab? It acts on rank L ligand. So if you know the osteoclast mechanism, so osteoclasts are activated by this rank L, right? So we are going to stop the resorption. So again there is decrease in the resorption, that is by your denosumab, right? And then you can even give calcitonin, but usually now research has been shown that there is no much improvement in osteoporosis with calcitonin. Calcitonin also, this nasal spray we get. So usually we prescribe the nasal spray calcitonin, right? And then we have parathyroid hormone, PTH. Parathyroid hormone also is used in teriparatide. It is a synthetic parathyroid hormone which is used for, again, treatment of your osteoporosis, right? And then we have strontium. This strontium acts both as decrease in resorption and increase in bone formation, right? So strontium rallinate is one drug which can increase the bone formation as well as decrease your resorption. This you have to remember. That is your strontium rallinate, right? And then we have okay. So these are the various things. Whereas drugs which are being available for treating osteoporosis, but the most important one which you have to remember is bisphosphonates, right? So then you will remember the denosumab and calcitonin, not much. And this PTH is a hormone, synthetic teriparatide. This we give in pulsatile fashion, right? This increases sometimes, sometimes usually it is given as a post treatment, right? Once we treat the patient with fractures, we can prescribe the PTH to them. And then strontium rhodonate. Here there is two things in strontium. What you have to remember, it increases the formation and also decreases the resorption. Well, all this will usually decrease the resorption, right? Okay, this is the treatment for your osteoporosis. This is what you have to write for the treatment of your osteoporosis. Is that clear? And sometimes, to increase the vertebral height, what we do is, this is called as vertebroplasty. Vertebroplasty or balloonplasty, where they will inject cement. They inject cement into the vertebra to increase the height. So this increases the height of the vertebra. So this is the vertebroplasty. So this is one of the invasive technique which is available for your treatment of the vertebral kyphosis, or to increase the height of the vertebra. Okay, this is called the vertebroplasty. Someone is feeling sleepy? So that's it for the treatment of your osteoporosis, and I hope this will work for you for the theory especially. So you're going to start right away from the definition. As we all know, it is the one word bone mineral density decrease. And then we have the causes as well as the risk factors, which are very, very important, and the clinical features. And the most important thing for diagnosis or screening is the DEXA scan, which we have. And then we go for the radiological findings, right? And then we have learned about the Singh's index, which is used for grading of osteoporosis. Then the treatment part. So the treatment, remember, it is not only giving them the treatment, that is, just prescribing some medications doesn't help osteoporosis, because there are multifactorial involved in it. You have to correct the diet, the lifestyle modifications, such as you have to quit smoking and alcohol, and then you have to encourage them to do the exercises, and then treat them with so and so drug which is suitable to the patient. Hence you can treat the osteoporosis in whole, right? So that is about the osteoporosis. So then we are done with the metabolic disorders. Then let's jump to peripheral nerve diseases. Okay, so here we are dealing with two nerves today. One is your ulnar nerve palsy and the second one is your radial nerve palsy. Both these two are also important in the exam. So first, coming to the ulnar nerve, as you know, ulnar nerve, what is the root value of ulnar nerve? Yes. So you have to always, any nerve you're starting, the answer should always start with the root value. Okay. Then only the examiner will know that you also know the roots of orthopedics. Okay. So the roots always starts with the anatomy, right? So anatomy, where the root starts, it is from the brachial plexus. So the medial cord of the brachial plexus, where the root value is C8 and T1 for the ulnar nerve. Okay. Then you have to always force. So where it is starting and where it is ending. So we all know that the root value of the ulnar nerve is C8 and T1, and it courses right from the axilla like this. So this is the medial cord. It continues as the ulnar nerve like this, if you see. And here in the middle of your arm, this is called the arm, right? So here it pierces one important structure which is called as, so the medial cord continues as ulnar nerve. In the arm, it pierces the medial intermuscular septum. And usually it is present on the medial side only of the arm. And it pierces the medial intermuscular septum, and then it enters the cubital tunnel, and it enters into the forearm, Here you have to remember that it is between two heads of flexor carpi ulnaris. So this you have to remember. So once in the arm, usually it is present on the medial side if you see, and here it pierces one important structure, the medial, say, intermuscular septum, and it is usually the most superficial peripheral nerve, and it can be easily palpated. Where and how do you palpate? We have seen in the MedEd clinics, right? So palpation is behind the medial epicondyle, right? And that for that you have to flex the elbow 30 degrees of flexion, and then behind you have to palpate for the medial epicondyle, which is a bony prominence, and just behind it on the medial side you will see a structure which is rubbery structure, you know, cord like rubbery structure which moves, and that is your nothing but your ulnar nerve. And once it enters the cubital tunnel, from there it enters into the forearm between the two heads of the flexa carpi ulnaris. So this you have to remember again. So it enters between two heads of FCU, and again it is present on the medial side along with the ulnar artery. It traverses whole of the forearm, right? Whole of the forearm, and then it reaches the Guyon's canal to enter into the hand, and this is formed by the pisiform, right? Pisiform and the hamate. So this is pisohamate structure, and then that is called the Guyon's canal, where your ulnar nerve is present, and from the Guyon's canal it enters into the hand and it supplies all the muscles of the hand. So that is the not you know, it's a brief introduction to the course. This much is enough for the exam. And then once the course is done, then it is the muscle supply, right? So then it comes to the muscle supply. So now hope you understood the course. So here remember, from the axilla it enters on the medial side. Here it pierces the medial intermuscular septum, and then it goes behind the medial epicondyle. This, while it is going, this is the cubital tunnel, and then it enters into the forearm. This is the forearm, where between the two heads of flexor carpi ulnaris, and along the length of the forearm it traverses on the medial side along with the ulnar artery. And once it enters the wrist joint, here there is Guyon's canal, which is formed by the carpal, that is carpal bones, and then from the Guyon's canal it enters into the hand, which divides into superficial and deep branches. So it supplies muscles especially in the forearm and the hand. So there is no muscle supply in the arm, right? This you have to remember. So there is no muscle supply in the arm, and once it enters the forearm it supplies all the flexors, that is flexor carpi ulnaris, plus half of, which half? That is medial half of flexor digitorum profundus in the forearm, and it is usually called the musician's nerve because it supplies most of the intrinsic muscles of the hand, right? So what are those important intrinsic muscles of the hand? It supplies the, what are those muscles? I know you're very well versed with it. Yes, hypothenar group of muscles. It supplies the palmar interossei, dorsal interossei, incomplete. Then it supplies the third and fourth lumbricals. Again, if you see, the third and fourth is on the medial side, so usually on the medial side. And then the most important one of the thenar muscle, that is your adductor pollicis, though it is a thenar group but is supplied by the ulna. So this is the exception which you have to remember, right? So these are the muscles. So now if you see, the same thing, right? So, and this is the motor supply, what I've told you. sensory is 1.5 fingers on palmar and dorsal aspect. So it is a mixed branch which has both motor and the sensory supply. So motor is nothing but your muscle supply, right? And now if you see, you can just draw this beautiful diagram in the exam, which will, give you more marks. And now you will also not get confused. So we know this is the root value of C8 and T1, as we have discussed. It doesn't give any branches up to the arm, right? No branches given up to the arm. Then it enters the forearm, where it gives a complete flexor carpi ulnaris, because you know that it is in the substance of this. In the two heads it divides, right? Obviously it has applied the two heads. Then you know the medial half of FDP. Remember, it is not FDS, it is FDP, flexor digitorum profundus. Flexor digitorum profundus. FDS is supplied by your median nerve. Why do you remember FDP? Because this is a deep muscle, not a superficial muscle. Deep muscle, deep group of flexors. Okay, so that is the flexor digitorum profundus, right? That is only the medial side. And then it enters the hand. In the hand, it enters through the Guyon's canal. And here it supplies all the intrinsic muscles. So first it is hypothenar eminence, I have told you. So there are three important muscles. You can see on the screen: minimi, that is flexor digiti minimi, opponens digiti minimi, abductor digiti minimi. So whenever we say minimi, it is on the little finger, right? And then I have told you there is an exception, that is your thenar group of muscle. Whenever it is pollicis, it is thumb. But adductor pollicis is one such muscle which is supplied by the ulnar nerve and not the median nerve. And third and fourth lumbricals and all your palmar and dorsal interosseous, right? And this palmaris brevis, you can remember this also. It is usually and not such much useful muscle, okay? And then it supplies the skin of 1.5. I have told you, 1.5 dorsal side and the palmar side. Okay, so this is the supply. So this is the, so you can also remember it supplies the joints as it is going through the elbow joint and the wrist joint. That's it. Okay. So this is the supply. This is the supply of the ulnar nerve, which is very, very important. If you draw this diagram, they will give you half of the marks. So now the thing is, what are the clinical features? And what happens if there is a problem to this ulnar nerve, and why actually this palsy occur? So the palsy, usually it could be the reason of, trauma, that is cut, laceration, which is very, very common. And then it could be leprosy sometimes, which is not very common nowadays. And then it could be a deformity, such as your tardy ulnar nerve palsy, right? These are some of the causes why actually these palsies occur. So some of the causes, right? And now we are going to see some of the important clinical features. What happens if there is a palsy? So the first and foremost is your, what is this called? What is this picture speaking about? Yes. So this is nothing but your claw hand, right? This is nothing but your claw hand. Zeus is, can't there is any problem? So if you see claw hand, what is actually claw hand? Claw hand is, there is a problem with the lumbricals, right? And whenever there is a problem with lumbricals, this results in claw hand, which is extension of MCP, or sometimes it is hyperextension also with flexion of IP, that is interpharyngeal joint. So that is nothing but your claw hand. Okay, and here you can also see there is atrophy of hypothenar muscle. So whenever there is, and one more thing for palsy, you know, the causes, they could be compression myelopathy, compressive syndromes, such as, you know, it can get compressed in the Guyon's canal or cubital tunnel syndrome, right? So the compressive syndromes also can result in nerve palsies. So here you see that there is an hypothenar, this atrophy. So you can see this is big and bulging, no? So flattening of this muscle. So this is hypothenar atrophy. Then you see there is a claw hand. This is called clawing. And now whenever I see a claw hand, then you have to diagnose it whether this is actually a ulnar nerve palsy. So for that we have certain tests for ulnar nerve palsy. So we have completed the root value, the course, and then we have seen what actually happens. So what is that important deformity in ulnar nerve, right? And this clinical features, they can present with deformity or they can present with tingling and numbness, right? So usually we see on the medial aspect. So these are certain symptoms which the patient tells, you know, there would be deformity, there would be tingling and numbness, and there could be weakness of that particular muscles. So these are the clinical features which they present with. So how do you test them? So what are the tests for ulnar nerve palsy? So the first test is called the card test. So card test is mainly for pad, that is palmar interossei, which will test your adduction. Then we have your igawa, and this is for dorsal interossei, which test for your abduction. Then for book test, so book test we have for adductor pollicis. Book test is for adductor pollicis. So this is very, very important. And in the book test, there is also the Fromen's sign. So these are the tests which you have to remember. So one is the card test, Igawa test, and the book test. So now I'll show you what is card test. So this is your card test. So now what is happening there? So you're putting the card in between the fingers and you're trying to pull them against the patient, right? So this is testing your adduction, adductors muscles, or like palmar muscles, palmar interossei, which are usually responsible for adduction of fingers, right? And then we have igawa. Igawa is nothing but place your palm on the desk and then you do the abduction of the middle finger. So you have to just move this middle finger, so whether it is abducting or not. So this is the movement. So you put it like this and then you move. This is the abduction, okay, abduction muscle. And then we have the book test. I have told you this is the book test. So this is, we are testing for the adductor pollicis, and whenever you're bending the thumb on this test, then that is Fromen's sign. Then that is your Fromen's, right? This is your Fromen's sign. Book test is for adductor pollicis. So similarly, like the card, you will give book and then you will test for adducting. So now the patient is asked to hold the book like this, and if he is unable to do the book holding properly with the help of adduction, instead of adduction he is flexing the thumb. He is using his flexor pollicis instead of adductor pollicis. So whenever he is using flexor pollicis, that means adductor pollicis is weakened. So there is an ulnar nerve palsy which we can identify, and this is called as the book sign or the Fromen's sign. So these are all the things which you have to observe in the ulnar nerve palsy patient, right? And then you will look for sensations, right? Sensations, where will you look? You will look for the, where? 1.5 fingers, right? On the medial side. The medial side. And then you have to remember there is an autonomous zone. Autonomous zone is nothing but which is very, very specific and highly specific for ulnar nerve, that is tip of the little finger. So this is the tip of the little finger. So this is the autonomous zone where you will, this is no, there is no lapping of any other nerves. Only ulnar nerve is responsible for the tip. So there you will check for the sensations like numbness, tingling. Okay. So these are the signs where you can diagnose a patient with the ulnar nerve palsy. So here you have to remember that there are two types. So there is high ulnar nerve palsy and then there is low ulnar nerve palsy. So whenever I talk about high ulnar nerve palsy, that means the forearm muscles are also involved. Okay. And when I talk low ulnar nerve palsy, it is only the hand or the intrinsic muscles which are involved. Right? And now coming to the management, that is the treatment part. Treatment is always you start with the splinting plus physiotherapy, right? So usually we start with splinting and physiotherapy, and splinting we already know what we use. The splint name is your knuckle bender splint. So this is your knuckle bender splint. So this is the splint which we put, and if you see what is the splint doing, it is flexing, right? Flexing the MCP and extending the IP. This is the action of your lumbricals, right? If you remember the action of the lumbricals, flexion of MCP and extension of IP, right? So similarly, we are using the knuckle bender and getting the same effect. Okay, so this is splinting and physiotherapy. And then sometimes if it is not recovering, you can go for the tendon transfers, right? So you will replace the tendons and you can go for the tendons transfer, right? So this is about the treatment of the ulnar nerve palsy. So usually what they concentrate is about the test of the ulnar nerves and then the claw hand. So they will ask you to write about the claw hand. Just they can give you to write about the claw hand. Then you have to be very careful to write about the clawing. So why it is actually called the claw hand and what is actually the mechanism which is happening here. And then they will ask you about the test which we have dealt in detail. So if they ask you about 10 marks, usually you start with the course, that is root value, course, and then you will write the muscle supply. Then you will write the clinical features with the palsies and the test, the causes of the palsy, then the test, then the management. Management is usually at your level, splinting plus physiotherapy would be sufficient. And if you write the tendon transfer, it is very much welcome, right? So that is about your ulnar nerve palsy. Okay, is that clear? Any doubts? Anything you want me to repeat? Done, everybody? Okay. Okay, if you're done with the ulnar nerve, then there is one more important nerve. Usually they will ask about the radial nerve. So radial nerve is usually the examiner's favorite. Okay, when I was in my first year, no, we have got this radial nerve essay, that is course of the radial nerve and the muscle supply of the radial nerve and the clinical features. This was in the anatomy only, the first year only. So this was given for the internal, first internal. Okay, then again they have repeated it for the pre-finals. Then again in the final exam we have got the radial nerve. So almost we are like done with the radial nerve. You know, every exam there was a question about the radial nerve. That important it is. Okay, ready to learn about the radial nerve, everybody? So radial nerve, very, very important, nerve of the upper limb. And the course, what is the course of the radial nerve? Somebody? What is the course of the radial nerve? It is from the which cord? It is from the which cord? So if you all remember, the radial nerve is one nerve which is from the posterior cord, right? And posterior cord as all the things, right? C5, C6, C7, C8 and T1. Right? So this is from the posterior cord. So this is the root value. And now we will discuss about the course. So course, if you remember, it is the posterior cord. So radial nerve starts from the posterior cord and usually it enters the axilla and then it enters on the posterior aspect of the arm. Right? And here, if you remember, on the posterior aspect, it enters the radial groove. Right? Radial groove. On the posterior aspect, from the radial groove, it pierces the lateral intermuscular septum. If you remember, that was medial intermuscular septum for ulnar nerve, and for the radial nerve, it is on the lateral side, that is lateral intermuscular septum. And here, as the ulnar nerve, this pierces supinator muscle. It pierces the supinator muscle, right? And then enters the forearm. And it supplies all the extensors of the forearm. Right? It supplies all the extensors of the forearm. That is the course of the radial nerve. So if you see this particular picture, here you can see that this is the radial nerve posterior cord, and here it is entering this quadrangular space, right? You say this as quadrangular space, right? And then it enters the triangular space here, the small triangular space. Okay, and now this is on the posterior aspect, if you see, and this is the radial groove. So this is the radial groove, and here it passes the lateral intermuscular septum and it enters the forearm in the substance of the supinator muscle. So this is what you have to remember, that is the supinator muscle. So here what you have to remember is, in the arm it gives to one and only extension muscle of the arm, that is your triceps. So it supplies triceps. So three heads, right? Long head, medial head and the lateral head. Right? It supplies all the three heads of the triceps, and this is one and only one extensor of the arm present on the posterior aspect, and your radial nerve supplies all the three heads of that triceps, right? And once it enters into the forearm, so it is in the supinator, it divides also, where it gives a branch which is called as posterior interosseous nerve. So this posterior interosseous nerve will supply the extensors of your and the hand. I mean the fingers, extensors of the fingers to be precise. Pin usually supplies the extensors of the fingers, right? Extensors of the fingers, right? So that is how you have to remember the radial nerve. One second, here I just forgot to tell that the ulnar nerve also have a branch which is called the AIN, right? Anterior interosseous nerve. So there is an O sign which you have to remember. Kilonavin sign. So this is the O sign for anterior interosseous nerve. Sorry. That is the branch of median nerve. Okay, done. So ulnar nerve is done. Nothing to add. Sorry. I was confused. Okay. Okay, now getting back to the radial nerve. So radial nerve, again, you have to remember that that is the most important thing, the extension, that is triceps, what we are talking about. And then it supplies all the muscles of extensor muscle. And then there is a branch of the radial nerve, which is called as the pin, that is posterior interosseous nerve. And it supplies the fingers, extension of the fingers, right? So now we are going to deal with this. So now this is similarly the diagram which I have showed you the previous one. So here you have to just remember that triceps. So there is only one muscle, that is the triceps in the arm. Then it supplies the brachioradialis. As it is entering into the forearm, it supplies three important muscles. So first is brachioradialis, extensor carpi radialis longus, and extensor carpi radialis brevis. So once it supplies all these three muscles, and you have to remember these two are the wrist extensors. So wrist extensors are these two. So extensor carpi radialis longus and extensor carpi radialis brevis. And once it enters the supinator, remember it gives the branch, that is pin, posterior interosseous nerve. And these are all the muscles which are supplied by the pin, and then it continues as superficial radial nerve, right? It continues superficial radial nerve, and there is no muscles which it gives supplies in the hand. Okay, so these are the all the extensors which are supplied by the radial nerve. Only two things you have to remember regarding the course. So first is it travels along the your quadrangular space, triangular space, and then it enters the posterior surface of the humerus in the radial groove where it supplies the triceps. And once it is entering into the elbow where it's piercing the lateral intramuscular septum, it supplies three important muscles: the brachioradialis, the extensor carpi radialis longus, extensor carpi radialis brevis. And these two are the wrist extensors. And finger extension, once it gives branch to the supinator, then it divides into a posterior interosseous nerve, which is the D branch, and then it supplies all the rest of the extensors, usually the finger extensors such as extensor digitorum, digiti minimi, pollicis longus, pollicis brevis, indicis. Okay, then it continues as a superficial radial nerve, which is seen on the dorsal aspect. I mean on the dorsal forearm. Okay, this is a superficial radial nerve, and this is the force and the nerve supply, right? And now what happens whenever there is a damage to the radial nerve? So we are entering into radial nerve palsy. So usually this radial nerve gets damaged because of trauma, fracture, and one such important fracture is fracture humerus, especially at the level of junction of middle and the distal 1/3. That means where it is coming from the radial groove, and whenever it is piercing the lateral intramuscular septum, here the nerve gets crushed. So at the level of the lateral intramuscular septum, it is tightly attached to the septum. So it can't get escaped, it cannot escape and get crushed between the fragments. So this particular fracture is called as Holsten-Lewis fracture, right? So this is one of the most important cause of radial nerve palsy. And the second one is axillary compression. This compression can be because of uses of crutches or one important condition. Yes, all my dear friends, what is that important condition of radial nerve palsy? Yes, that is your Saturday night palsy. Okay, Saturday night palsy. So there will be a binge drinking on the Saturday, and then the patient will land with this Saturday night palsy, right? So these are the things where we usually see. And then what happens? Patient develops in what is called as wrist drop. So what is the outcome of this radial nerve palsy? It is the wrist drop. So this diagram you can draw in the exam. So just a humerus and then the radial nerve passing through it whenever there is a fracture. So now if this is the humerus, so this is the humerus, right? It is divided into proximal. Okay, this could be the proximal area, middle area, and the distal area, right? So junction of the middle and distal, this is what I meant. So middle and the distal junction, whenever there is a fracture, it gets tethered to that lateral intermuscular septum and get crushed between these two fragments, resulting in Holstein-Lewis fracture. And then we have this binge drinking of the patient where there is a compression in the axilla, which will result in the wrist drop. So this is your wrist drop. So why there is a wrist drop? Because there is a weakness of wrist extensors, right? So there is a weakness of the wrist extensor. So there is a loss of extension. So again, you remember the radial nerve palsy is of two types. So there is high radial nerve palsy and there is low radial nerve palsy and there is very high. So whenever I talk about high radial nerve palsy, I mean it is something around the elbow which results in wrist drop, right? And if I talk about low radial nerve palsy, it is about the finger drop. So something in the forearm, right? And then very high, usually in the axilla, and this will result in triceps weakness. So there will be weakness of the triceps as well. Here, triceps normal. Very high, there will be triceps weakness. So here, usually what are disturbed, as I've told you, longus and brevis. So that is why there is problem in the wrist. So the wrist extension is lost. That is high radial nerve palsy. Low is finger drop, where there is problem to the pin, right? Only one finger or three fingers like that. So there will be finger drop. And whenever there is a triceps weakness, that is very high radial palsy. And this is a very rare entity, right? It's a very rare entity. Okay. Okay, that's it about the radial nerve. And then how do you examine it? Examination you do by checking the extension, right? And muscle strength. So you will see the muscle, that is extension. You will do tricep extension, that is elbow. And then you will test for muscle, that is the wrist. You will test for longus and the brevis, right? So that is how you do, how you actually come to a conclusion. So this is very, very, clinical diagnosis is very simple. So you will have drop and then you will tell which palsy it is. But here I want you to remember that the treatment part, management or treatment, again you go for splint plus physiotherapy. So here what you have to remember, there are two types of splint which are named as the cock-up splint. So this cock-up splint is again a static type and a dynamic type, right? Yes, which one is static, which one is dynamic? What is A and what is B? Quick, faster. Yeah, which one? A is what? Dynamic or static? It's a IBQ, image-based question. ये है dynamic और ये है static. So dynamic, you can see there are springs attached to it. So it keeps moving. Movement is nothing but dynamics, right? Static is stable, just a resting functional position. That is static, where the wrist is put in neutral position. So that is the resting position or functional position of the joint. So that is how splints are used, right? So splints are used to put that particular joint in the functional position. So that is the work. I mean, that is the essence of using the splint. Okay. Then the most important thing, the treatment part in case of radial nerve palsy is tendon transfer. So if the patient is not recovering over a period of time, usually we put arbitrarily as 6 months, then we go for tendon transfers, right? So here the most important is your extensor carpi radialis longus and extensor carpi radialis brevis. So this is transferred, we use the pronator teres, right? Use the pronator teres for this, and that tendon we get transferred to this, right? And next thing is extensor digitorum communis, right? For fingers we use extensor carpi ulnaris, and this is called as the Jones transfer, and it is one of the successful tendon transfer. So you have to remember it is the Jones tendon transfer, where your both the wrist extensors are being replaced by your pronator teres, and whenever there is a finger drop, like for example communis, then you can use your carpi ulnaris. And the most important thing, your thumb extension is very, very important, right? So for that, that is extensor pollicis, right? Extensor pollicis. So this you can use the extensor, sorry, not the extensor, you will use the flexor carpi radialis, right? So flexor carpi radialis. So that is how these are the tendon transfers. Not much required at your level, but if you remember, it is very, very good on your part. You have to just remember that the tendon transfers is one of the important treatment choices for nerve palsies, right? And in that, especially the radial nerve is mainly the pronator teres acts perfectly for your extensors of the wrist, which is called as the Jones tendon transfer. It is one of the most successful tendon transfers, and you have to remember the name. Just remember in ulnaris and radialis is very, very important for, right? So this radialis is used for important thing, that is thumb, and ulnaris is used for the finger drop. That's it. So that completes your ulnar nerve palsy and radial nerve palsy. The peripheral nerves are done, and then we are left out with two important topics, that is your de Quervain's tenosynovitis. So what is this de Quervain's tenosynovitis? Yes, anybody? So if you remember, as we are talking about the extensors, you remember these extensors of the forearm are arranged in 6 compartments, right? And whenever there is inflammation of the first compartment extensor muscle group, and what is the inflammation? It is the tendon sheath inflammation, right? Tenosynovitis. So the synovium, that layer which is covering the tendon, the synovial sheath gets inflamed. Okay, so which tenosynovitis this is? This is APL and EPB. It is abductor pollicis longus and extensor pollicis brevis, right? So these two are APL and EPB. If you see this particular picture, you will have an idea. This is the tendon I was talking about, and this is the synovial sheath, right, which is covering the tendon. So APL and EPB, so abductor pollicis longus and extensor pollicis brevis. This is the first compartment muscles, and whenever there is an inflammation of this tendon sheath, that is tenosynovitis. tendon synovium inflammation. Itis is inflammation, right? So here then you call this as a condition which is called as the de Quervain's tenosynovitis, and one of the most common clinical condition which we see. And where it is usually seen, in which individuals it is usually seen, and this is mainly seen in the repetitive activity. So the causes of this is repetitive activities, like screwing, so that carpenters, excessive usage of the tendons will result in the inflammation, sometimes even in pregnancy, sometimes in obesity, right? So these are the areas where we usually see with the repetitive pregnancy and obesity. This is the de Quervain's tenosynovitis. And what is the test which is usually responsible? So this is called as the Finkelstein's test. So what is Finkelstein test? JA, what is your question? What is myotome C6? What is that? I mean, regarding, I am not clearly understanding what is your doubt. Put the doubt properly so that I can help you with the answer. So what is Finkelstein's test? Finkelstein's test is mainly the test which is used for diagnosing your de Quervain's tenosynovitis, the condition. And how do you do that? So here we already know that the first compartment muscles, so these are the two important tendons, the first compartment tendons, right? APL and EPB. And what will happen to them? You're going to fold. For de Quervain's, the myotome you're asking? So you're going to fold the thumb inside, and then you're going to create a fist like this, and then you ask the patient to extend. So you're going to ulnar deviate like this, right? So whenever you're going to deviate like this, there will be and stretch over these tendons of the first compartment, right? So whenever there is a stretch of this first compartment, then they will cause pain. So this pain, whenever it is induced by the deviation or extension, it is called as the Finkelstein's test. So Finkelstein's test is your de Quervain's tenosynovitis, right? So that is your Finkelstein's test. And how do you treat it? So once you have understood the pathology, the treatment is, you will, ultrasound is one such which will help you in the diagnosis. Right? And then the treatment is, you can release the compartment. It is a small invasive procedure. So before that, you can try with NSAIDs and rest, steroid injection. So all this can be done, but the ultimate treatment which will give a perfect relief is release the compartment. So you give a small incision and decompress. Right, small incision we give and decompress. Yeah, clump case is also the same. Clump case palsy is also the same. Why? Because there also the lower trunk, that is the C8 and T1 is involved. Yes, clump case is also can be considered the same, because ulnar palsy is also C8 and T1, and clump case palsy is the involvement of the lower trunk, that is C8 and T1. Yes. JAM. Sorry, what do you mean by this myotome C6 and T1? For which nerve? Ulnar nerve you're talking, or decurvens. Decurvens, there is only two important tendons which get inflamed here. That is APL and EPP. Okay. And usually C6. Even if you're talking, it could be a dermatome. Suiscan, your doubt is cleared. Clump and ulnar nerve can be considered the same, okay? Because usually C8 and T1 is involved in clump palsy also. So that is about the decurvens tenosynovitis. Okay, so now we are going to, this is not a long question, it is only a short one. So you will first tell me which muscles get involved, that is APL and EPB. Yeah, it is usually unilateral only. And then the conditions we are going to write. And then the test, the most important thing they will look for here for the tests, the Finkelstein's test, and then the treatment. So they were going to decompress the particular tendon, and then patient gets relieved from the pressure, right? And then we have one more important thing, that is Osgood-Schlatter disease. Osgood-Schlatter disease, right? So what is this? Yeah, same, one side. So what is Osgood-Schlatter disease? So this is the apophysitis. So what is an apophysitis? So what is an apophysis? Yes. What is an apophysis? Apophysitis. So here you know what is physis, right? So we know what is a physis. Physis is the which increases the length of the bone, right? And what is apophysis? So apophysis is that particular thing which increases the, yeah, physis is growth plate. Apophysis is, it is responsible for the circumference of the bone, or circumferential increase, that is like it is present, it can grow like the, this is called the circumference, right? So this growth of the circumferential growth is responsible by the apophysis. So whenever there is tibial tubercle apophysitis, so that is called your Osgood's Schlatter disease, right? So that is your tibial tubercle apophysitis. And what will happen here? It is because the cause is usually seen in the growing age, right? With the excessive activity, right? Excessive activity such as whenever they play badminton or any athletic sport, which is, you know, without they have this increase in pain on activity, and usually relieved on rest. It is usually relieved on rest. And one more thing what you have to remember is this is a self-limiting disease. It is a self-limiting disease. So it just, stops on its own, self-limiting disease. So what you have to be careful is which activities causing the pain should be restricted, right? And you have to assure the patient that this is a self-limiting disease and it is because of this inflammation of the apophysis which is resulting in the pain. So pain where you see, usually they show you at the tibial tuberosity. So tibial tuberosity, there will be pain, and then usually they say there is an increased pain on activity, so it is again relieved on rest. And once the complete fusion occurs or complete growth, so usually it's the pain disappears, right? So what do you treat? You treat with the NSAIDs again for the pain, and you relieve the rest, right? And restriction of the activity. So activity gets restricted. So this is how you treat the Osgood-Schlatter's disease. This is also just for a 2 marks or a 4 marks, a very small question this is. So first you will write what? The Osgood-Schlatter's disease is a tibial tubercle apophysitis and usually seen in growing age. So what do you mean by apophysis? Is which increases the circumference of the bone, right? So this is the tibial tubercle area where the patient complains of pain, and usually the pain increases on the activity and decreases on the rest, right? And now how do you treat it? You treat, sometimes you can even prescribe the knee brace also to them. So you will treat with first with the rest, then NSAIDs, then knee brace, then restriction of the activity, and finally you will tell them this is a self-limiting disease. So once the growth is completed, then the pain subsides automatically. Okay, so that is about your Osgood-Schlatter's disease. Okay, so this completes the entire Farre series, right? So this is the MedEd 2.0. We have come up with various good programs, such as the Farre series, where this is more going to help you for your prof exams, right? All the repeated questions, frequently asked questions are put up, and then we are dealing with that series, that is Farre. And then we have the clinical corner. This is the clinical corner. We have completed most of the topics from the MedEd Orthopedics clinical corner. You can check them on the YouTube as well. And then we have this 3D models. 3D models will help you increase your perception of, the presence. For example, if I told you that it is passing to the intermuscular septum, then you can see it on the 3D model as well, which will increase your creativity and it will become easy for you to understand the concepts behind the subject, right? So that is the MedVerse 3D. These are some of the important features of the MedEd 2.0. Okay, so that completes the Farre for orthopedics. So thank you so much. Now open for the discussions. Any doubts you have? Yes. Any doubts? Anything you want to share? Anything? Any important questions still you want me to teach or explain? So first, put in your mind that this is for your prof exams, right? So how do you approach answer? How do you write in the exam is important here. So that is what we have put as the main priority, that it should help you to clear the prof exams and as well as to get good marks. So anything else you want, any question you want me to add on? Because we have collected a set of questions and we have completed all of them. So this is the 4th class. So you can see all the other 3 classes in the YouTube as well. So if there are no doubts, so that's it for today. Okay. If you want to clear any of your doubts, I'm available on Ortho, Dr. Alekhya Ortho. This is my Instagram ID. Or you can approach the PW MedEd Instagram handle team as well. I can surely throw much of the questions. So whatever I want to throw, I have already thrown on the YouTube. You can just go and check there. So we have covered almost like 30 questions from ortho. That should be quite enough from my side. Okay. Okay, so these two are the Instagram handles which you can follow, and you can ask your queries there as well. Keep following the PW MedEd Insta because all the updates will be given there, and now we are running Telegram group as well. So you can join on the Telegram group so that you will not miss any further classes. Okay. See you all. Good night. Thank you. Jones fracture is fifth metatarsal, no? I think Zuiscan, we are done with the Farre now. All the important questions are done. So Jones fracture is the, see, that is a little bit elaborate topic, the Jones fracture. What you have to understand is if this is the metatarsal, there is a tendon attached to here. So what happens is this tendon keeps pulling the fragment. So this is the fracture. So this tendon keeps pulling. So here we have three zones, zone 1, 2 and 3. And here the zone 2 is considered as the watershed zone. Okay, so the blood supply is very, very minimal there. So if it is zone 1, it is okay, but 2 and 3, you have to go for surgery. Okay. So because the tendon which is there, it keeps constantly pulling the fragment and will not allow it to heal. So if it is a classical, displacement in zone 2 and 3, then you have to go for your surgery in Jones fracture. And Zoe scan, this is the last class for Farre Ortho. And if you want any more questions, you can put in the comments so that we will take at least, if there are some like 3 or 4 questions you want me to teach, then we can take one more class for Farre. Okay. Jay, that clears your answer? What we do normally? So just an avulsion fracture is called the pseudo Jones. Just the tuberosity avulsion fracture is called the pseudo Jones. Okay. So that is what we actually, surgery is done for zone 2 and zone 3. Right. So this is just a avulsion, tuberosity avulsion fracture. Actually, if you are, that depends upon the patient also. If the patient is highly demanding, you can actually do the surgery for all the 3 zones. But usually we do it for zone 2 and zone 3. Okay, so that's it for today. Thank you so much. Bye.